On behalf of the Rehab, Refit, Return to Duty program, I'm Dr. Jeff Leggit, and I'll be discussing low back pain today. I have no conflict of interest to disclose, and the views that follow are those of mine alone that do not represent those of the Uniformed Services University of the Health Sciences, nor the Army, nor the Department of Defense as a whole. During the session, please mute your line or mic, track your participation, and provide feedback at the following link. In addition, if you have questions about specific patient issues, feel free to email me. To earn CME, you must be registered at the following portal, and do not complete the evaluation on the CME website until the end of the year, as this will exit you out of all future ECHO sessions. By the end of our talk, we will be able to answer the following questions. Which historical elements are the most important? What kind of physical exam needs to be done? Who needs imaging? How should you manage the non-surgical patient with acute pain and that with chronic pain? When should the patient initially follow up? And is there any way to prevent recurrences? How common is low back pain? It's very common, hence the reason we're discussing that today. What is the recurrence rate? Very frequent. 25 to 62% of patients experience repeat episodes within 1 to 2 years. And of those, what is their morbidity? Unfortunately, 33% have moderate pain and 15% have severe pain. What is the cost of low back pain? Direct cost is estimated to be $40 billion, with indirect costs, mostly from lost wages, at greater than $100 billion. What is the differential diagnosis for low back pain? By far and away, mechanical back pain, or nonspecific back pain, is number one at around 85%. As you can see from the following list, there is a large differential diagnosis, always considering referred pain as a possible etiology. Another way to think of this is in broad categories, such as nonspecific low back pain, or back pain with radicular symptoms, or spinal stenosis, back pain from another spinal cause, such as facet syndrome, and then again, the other category of referred pain from another source. It's important to talk about definitions. Acute back pain being defined as lasting less than 6 weeks. Fortunately, about 70% of people are recovered within this 6-week period. Then there's a subacute back pain, anywhere from 6 to 12 weeks. This is probably our target opportunity, as we can probably do the most good for these people. Once back pain goes greater than 12 weeks, it's considered chronic, and unfortunately those are prone to recurrence. Radicular symptoms, of which sciatica is an example of radicular symptoms, has pain or tingling or discomfort associated along a specific spinal nerve distribution, with sciatica along the sciatic nerve root. Radiculopathy differs from radicular symptoms in that there's actually sensory loss or weakness in the spinal nerve root distribution, while myelopathy is actual loss of function along either the upper or lower extremities. What are some of the factors that are associated with low back pain? Or disability claims for low back pain? Work that requires heavy lifting, bending, twisting, or vibration. Being generally physically inactive. Obesity is a risk factor for the majority of diseases, along with smoking. What are factors that predict worse outcomes at 1 year? They'll be very similar to the other list, but they also include non-organic signs and poor coping behaviors. The question remains, can we actually prevent a first occurrence? The evidence does not bear that out. Although regular exercise and maintenance of fitness may be helpful in preventing low back pains, evidence is insufficient to support the use of any specific preventive interventions, to include education, worksite prevention programs, or any mechanical support such as back brace. Let's discuss the pertinent anatomy of the back. The anatomy of the back is divided up into the dynamic portion, which includes the musculature, and the static portion, which includes the bony ligamentous structures, which will be shown later. When thinking of the musculature, we should talk in the components of superficial and deep. The deep components are varied and multiple, and this slide shows the multitude of muscles that comprise the deep musculature. And the point in showing these is that any of these can be sources of pathology, and sometimes it's very difficult to isolate which one is dysfunctional. In fact, when we do rehabilitation, we try to target all those. The other concept to consider when we're talking about the dynamic portion is the core musculature. And this is a good cross-section of the abdominal region, which talks about the core musculature. And when we think of this as a belt which will support these static structures such as the bone. And all these are sources that we would look to rehabilitate. Here we see our static components of the back. I'd like to draw your attention to the facet joint or the zygoepiphyseal joint, where the vertebrae stack on top of each other. And these are often a source of irritation or sources of pain, and they can be secondary to disc problems, and as the body tries to stabilize itself, they can be a source of pain. In addition, here are ligamentous structures, and you have anterior portion, and then you have the posterior portion here, and these can be sources of pain too, either primary or secondary. Here's a variety of disc pathology that we see, and here's a nice, healthy, normal disc. Here's a degenerative disc, the consequences of which have disc degeneration or osteophyte formation. As the disc degenerates or as it thins, the body, in an attempt to stabilize any movement, will create a bony osteophyte, and those osteophytes in and of themselves can be sources of irritation. And here's an example of actually a bulging disc where the disc is not ruptured, and then here's an example of a herniated disc where the disc is actually ruptured, and the contents of the disc will leak out and pinch on a nerve. And again, all these can be sources of pain. In fact, it can be very difficult to sort out which is the primary source of the pain, which is secondary, but they all can be sources of pain or dysfunction. Here are the essential elements of the medical encounter. Remembering that the goal is to search for red flags and or any specific diagnoses. In discussing red flags, we need to ask ourselves, how good are they actually? Unfortunately, there's a lack of consensus. Which ones are the most important ones? Even the definitions of the same ones in different consensus guidelines are different. And how accurate are they? Two recent Cochrane reviews looked at this. For spinal fractures, they found 29 different flags are identified, and for malignancy, there's 24 different ones. Of those, malignancy, history seemed to be the most important factor. And in fractures, these were the four important components. Older age, which is defined as 65 or 70, depending on which guideline you looked at. History of steroid use, needed to have some sort of trauma, and then some sort of lesion around the area of trauma. Multiple factors increase the risk of fracture even more. This is a good way to think about the red flags for serious etiologies. Here are your possible etiologies with their prevalence of occurrence, with cancer being less than 1%, Cauda Equina being quite rare, fracture being probably the more common one, and infection being quite a rare thing too. The important historical portion for cancers was, again, a history of cancer. For Cauda Equina, the history and the physical exams were important. For Cauda Equina, some sort of bowel or bladder problems. And in physical exam, any motor or sensory weakness would denote an issue. Fracture, again, the strongest thing was some sort of history of significant trauma. And then infection, the strongest risk factors for a historical element was a history of previous instrumentation in the last year, and then our cardinal signs of infection were important too. So these are good things to keep in mind, and remember our physical exam is searching for a specific diagnosis, our red flag, and remembering that 85% of the time it's a non-specific low back pain, which will have not very good historical elements and not very good physical exam elements. So in our history, we're looking for cancer, any systemic disease, any trauma or medication. When we actually do an inspection, is there any gross abnormalities, such as an abrasion or bruising along that area? Looking for any bony tenderness, actually palpating the spinous process. When we do our range of motion, we're actually looking for any reproduction of pain and also decrease in pain from range of motion. And we can use that to our advantage when we're just prescribing a rehabilitation process. And then when we actually do the physical exam portion, we will do a focused exam. Here are the elements of our focused exam with our motor and strength and sensation exams here. Here's a relative frequency of disc pathology along the lumbar disc, with L5 being the most common and S1 being the next most common. The motor portion of the exam is with asking the patient to raise their foot up, and then for the L5, it's actually just to raise their great toe up, and then to push down. So it's pretty easy to just do that in succession. Raise your foot against resistance, raise your toe against resistance, and then step down on the gas pedal, if you will. The reflexes are the patellar tendon and the Achilles tendon, realizing that there's no reflex for L5. And then sensation, you're just testing the inside of the foot, then the middle of the foot, and then the outside. So again, these are fairly easy to remember, even if you can't remember which specific nerve root they go to. The other essential component of the physical exam is the straight leg raise, in which you raise the leg to about 30 to 60 degrees and see if there's a sensation of pain or electricity going down the back or the side of the leg, and that would be a positive straight leg raise. This is a single leg hyperextension, which is looking for spondylolisthesis or spondylolisthesis. This is what's called a Faber test, or flexion, abduction, external rotation test, or figure 4 test, looking for hip pathology, if there's pain in the hip, and or if it's in the back, looking for sacroiliac pain. This is pain, a sign looking more for dysfunction of the gluteal muscles, where you ask the patient to stand on one leg. If they're strong on that side, the pelvis will stay neutral. If they are weak on that side, the pelvis will drop. And this is a good way to follow patients in rehabilitation to see if they are improving their core hip strengthening on there. Well, how good are these tests? So in and of itself, they don't have great sensitivity and specificity. So again, it's the composite of their history and physical exams. But you still need to do this, because remember, for things such as Cauda, Equina, any sensory loss or motor loss was very important. For straight leg raise, it's a little bit better, remembering that something that is a sensitive test, if it's negative, it essentially rules that disease out for a highly sensitive test. And for a specific test, if it's positive, it essentially rules that test in. And so for straight leg raise, it's a little bit better. I didn't talk about what a cross leg straight leg raise is. So if this is a single leg straight leg raise, a cross straight leg raise would be if we were worried about pathology down the right side or the right component of the vertebrae. If when we lifted their left leg, they had symptoms going down the right leg, i.e. a cross leg straight leg raise, it is highly specific that they have a right-sided disc disease. So again, I lift the left leg, there's symptoms going down the right leg, they have something wrong on the right side. So that's a highly specific test. You can be pretty comfortable with that. Unfortunately, the single leg hyperextension test has poor predictability of having active spondy disease. Let's talk a little bit more about the straight leg raise, and I see this in practice. Providers will lift their leg up past 70 degrees and say it's a positive straight leg raise. That's not necessarily the case. It's really in this area where you're putting maximal tension along the sciatic nerve root, and they will have symptoms here. And so it's really between 30 to 60 degrees that they would have symptoms that you would call this a positive straight leg raise. I'd like to draw your attention to the tri-service workflow low back pain AIM form, and it has all the elements that we need, so you don't have to memorize everything. Here's all our red flags here, and here is our sensation and motor strength and reflexes, and here are our special tests with our straight leg raise, and then here is the figure 4 or the Patrick test. I didn't discuss the Hoover test, and that's more of a test for malingering, and that is done while you hold one leg in your hand and you ask the patient to raise the other leg. For them to raise the other leg, other than the one you're holding, they must exert some sort of downward pressure on the leg that you're holding. Otherwise, they're not exerting any effort, and it's really a test for malingering, and that's what the Hoover test is. And the Babinski test is when we stroke the bottom of the foot looking for upper motor neuron test. So again, draw your attention to this tri-service workflow low back pain algorithm, or AIM form. It really has all their essential elements. It's a good thing to use. And so what are the things we don't want to miss? And we talked a little bit about Cauda equina, which is, again, quite rare. and then infections of the disc or the vertebral bodies. Remembering what Cauda-Equina syndrome is, so Cauda-Equina stands for horse's tails, and somewhere below the when the conus medullaris happens and you have the Cauda-Equina, there is some sort of compressive phenomena, either from a tumor or a disc compressing these structures, and really need to operate quite rapidly to prevent permanent loss. And so the most important thing is having some sort of bowel or bladder dysfunction. And if they have that, then you will do a much more careful, comprehensive physical exam looking for things such as sandal anesthesia. But if they have this raises your suspicion. And remember, that would be one of the reasons we get our MRI right away. And then what about discitis or vertebral diseases? Really, in adults, it can be a slow, insidious onset, but they will have some sort of history of a procedure or immunocompromise. Whereas children, it can be a very rapid onset, and they may refuse to walk. If they have a fever, it has high specificity. So again, quite likely that that's their diagnosis. And bone tenderness doesn't have quite a good specificity, but the sensitivity is okay. But these are the signs that you're looking for disc disease. But again, usually there's some sort of history of procedure or immunocompromise. I did mention MRI earlier. So when do we do imaging studies? I draw your attention to the Choosing Wisely campaign, and the number 2 thing on the Choosing Wisely campaign is don't obtain imaging studies in patients with non-specific low back pain. And specifically, it says in patients with back pain that cannot be attributed to a specific disease or spinal abnormality because of a good history of physical exam, i.e. they have non-specific low back pain. Imaging with X-rays, CTs, or MRIs do not improve patient outcomes on there. So don't do it if it's non-specific back pain. Now, if you're concerned about something such as Cauda-Equina, that's when you would get your imaging. So what imaging should you do and when? Well, who needs immediate imaging on there? So when should we get an MRI? So again, if we strongly are worried about infection, okay, if we think that there's signs of Cauda-Equina, and again, that's some sort of bowel or bladder problems, or they have severe neurologic disease, which is defined as progressive motor weakness or progressive motor defects at multiple levels. So just finding some minimal motor weakness or minimal sensory deficits, those can be followed. So remember, this talks about progressive motor defects and progressive sensory losses. Then you would get some immediate MRIs. Well, how about deferring after a trial therapy? So we see the patient back in 4 to 6 weeks, and they have progressive signs. So signs and symptoms of radiculopathy, which would include a positive result in straight leg raise or that cross straight leg raise. And these patients who wish to be considered for surgery or wish to be considered for epidural steroid injections, that's who you might get an MRI on. Are patients who had risk factors for spinal stenosis, such as a radiating leg pain or pseudoclaudication, who also are candidates for surgery. So again, what are their treatment goals? Those would be patients you would image on here. But remember, these are patients that had some sort of minor deficit to begin with, and it's not progressive. If it was progressive, then you would go to your MRI. Who doesn't need any imaging? Let's see if they meet no criteria for immediate imaging, our back pains improve, are resolved after 1 month of therapy. They do not need to get any imaging on there. And let's talk furthermore about MRI findings. So realize that 90% of us over 50 have some sort of disc disease that they'll find on autopsy. And then healthy people, 35% will have disc disease on MRI. So just because you see it doesn't mean it's actually a source of their pain. You must correlate with symptoms and what their treatment goals are. And so if they want to stay away from surgery, then don't get the imaging because it's not going to make a difference. And here's a good MRI of a sagittal view of what a normal healthy disc will look like. It's nice and white on here. Here this is dark, meaning it's lost some fluid content, so it's not a healthy disc. And this has a bulge, so it's pushing on this on the spinal cord. And this one actually is a rupture. It's a herniated disc, and that's pushing even further on that. And then here's where we see a transverse section of a herniated disc that's pushing in the spinal cord, and you can see that here too. So these are examples of MRI findings. But realize there's quite a bit of asymptomatic patients who have disc disease and MRIs, and you must always correlate that with their symptoms and treatment goals. Furthermore, when you get the MRI report and it talks about annular tears, I just wanted to show you what these actually mean. This is a circumferential tear, this is a radial tear, and this is a transverse tear of the annulus, which is actually the fibrocartilage structure which surrounds this, the actual disc, or the gelatinous material inside of the disc. When do we get advanced studies such as EMGs and nerve conduction tests? When you're trying to consider whether those are correlating to the imaging findings, so you're not sure if the radicular symptoms are truly from your MRI findings. Realize that you can't get those acutely because it takes at least 4 weeks for the nerves to become dysfunctional. So if you're unsure whether these nerve findings are because of the MRI finding, that's when you might get an EMG or a nerve conduction test on there. So how do we manage our patients on there? I would encourage you to consider using some assessment tools. One of the easier ones to use is the Keel Start Back Screening Tool, which you can download for free. And that has a series of 9 questions that each is scored for 1 point for a positive response on there. And the good thing about that is you total the scores up, and if they have 4 or more, they're in a high-risk category. If they have 3 or less, then they're a low-risk category. If you look at the subscores of 5 and 9, and that's here, these questions, it's not really safe for a person with this condition like mine to be physically active. That's what the patient feels like. Do they have overt worry, or are they very worried about their back pain? If they score positive on those tests, they may be managed in a medium risk category. But again, this can give you some comfort on some of the treatments that you're doing. And again, it's something you can follow longitudinally. So let's talk about, by far and away, the more common scenario will be the 85% who have nonspecific back pain management. Again, you want to establish what their goals are. Do they have an upcoming PT test? Are they going on deployment? Is their goal just to be able to do activities of daily living without pain? The most important thing you can do is to reestablish range of motion and strengthening. And we'll talk about that in a little bit further detail. Things such as yoga and Tai Chi and Pilates are very good to do. And they can help both do range of motion and strengthening. The most important thing is to stay active, and although weight control is very helpful to do, it's not always the easiest, but just in losing 5 to 10 pounds can make a world of difference in the back pain. We'll talk a little bit later about some of the adjuncts, but these are secondary to restoring range of motion strengthening. In fact, their use should be to increase these. These are by far and away the staples of the management of back pain. So which exercises should we do? It actually turns out it doesn't matter as long as you start doing something, but remembering that you want to work on this core, so you need to do some sort of abdominal exercises and some sort of superficial and deep back muscle strengthening. But the actual exercises doesn't matter. It's really just doing some of them. These are some common examples of exercises that would be important to do, and they will focus on again, more of the abdominal muscles and some of the back muscles. These are good examples, and then these will work on some of the hip musculature, which is very important too. But again, it doesn't matter which exercise you do as long as you do something. And how frequently should you do these exercises? You should be doing them daily with multiple sets. And your goal, again, is decrease the frequency of the pain, episodes, and durations. So remember, we talked about recurrence. It's quite likely that it's going to happen again. But the more likely that you do some sort of core exercises, the quicker you will recover from your back pains and the less frequent they will happen. So when we send patients to physical therapy, which of those modalities work the best? There's no good evidence for any of them except for heat for acute low back pain. So ice doesn't seem to be that beneficial. TENS units doesn't seem to have a lot of evidence for it, although there is lots of anecdotal evidence that those are helpful. But when we actually research it, it looks like heat may have some evidence for management of acute low back pain. There is evidence for a manipulation for chronic low back pain. The research does not bear out help in the acute scenario, but it can be helpful for chronic back pain. And then I don't want to discount cognitive behavioral therapy for psychological therapy. The patient who wants to get better is the one that's more likely to get better. And so this is where we get our multimodal therapies when we try to hit all of these. And talking more about the psychologically, what are the things we look for? We're hoping that we get patients that are the copers, so they want to get better. They want to carry on life as much as normal as possible, and they stay positive and active, and they believe they can help themselves. And research shows that they tend to get better faster and stay better longer, as opposed to the negative person who is the avoider. They fear the pain and worry about the future, and think pain means that there's damage in there. They don't take an active component in their rehab, and they wait for someone else to fix them. And what we found is they stay longer. How do we actually manage the patient who we believe have a herniated disc? Do we operate on them? Well, let's talk about the results of surgery. It really depends on the degree of herniation. So if they have a herniated disc and it has persistent leg symptoms, if a patient chooses to get surgery, there is about an 85% chance that their symptoms of leg symptoms will improve with herniation, not necessarily their back pain. So the patients without severe or progressive neurologic defects, so this tells you that we can follow these patients over a while and you don't need to send them to the surgeon right away. Without severe or progressive neurologic defects, really after 2 years, it doesn't matter whether you do surgery or you manage them medically. Their benefit will be the same. Now, there probably is a short-term benefit with surgery, meaning that they'll get better a little bit quicker, but at 2 years, they have about the same results. And of course, if you treat them medically, you do not risk the morbidity or mortality associated with surgical therapy. So again, just because you have a herniated disc doesn't mean you have to have surgery. What about epidural steroid injections? Well, there does seem to be some small short-term benefits, but there are still many questions about the epidural steroids. How quickly do you do them? How many do you do them? Now, they may help patients who to start moving a little bit quicker. So that patient who is in such severe pain that they can't do any rehabilitation, then really maybe that's a role for epidural steroid injections. You can also use them as a trial to see if that's where the source of pain is coming from. So if you were to inject some anesthesia and some steroid into the epidural space and their pain was totally relieved or the majority relieved, it's likely that it's some sort of spinal cord irritation that's causing their pain. Likewise, we don't talk about facet joint injections here, but you can do a facet joint injection to see the same thing. It's interesting about the practice patterns in the United States. We seem to have the highest spine surgery rate in the world, 5 times higher than the United Kingdom, and it's also geographic too. Same with interventional therapies. We do a lot more epidural steroid injections and intradiscal therapies than they do in other places. And this is also regional, where you see epidural steroid injections are recommended much more frequently or done much more frequently in Palm Springs than Honolulu, and both these were city locations. So practice patterns varies across the United States and across the world. I would draw your attention again to the Tri-Service Workflow Low Back Pain AIM form, and really this is a very good algorithm of how to manage it, and all the elements that we discussed here in this presentation will be here, so you don't have to memorize anything. And so if your patient has severe pain and they have red flags, you're going to go down this algorithm. If they don't have severe pain, and again it's nonspecific, then these are your treatment recommendations. And then let's talk about these a little bit more. And so again, they divide it up into acute or subacute. And remember, acute is either 4 to 6 weeks. We want our patients to remain active as possible. And here are the medications that you can try doing. Notice that they talk about spinal manipulation for acute pain here. We said there was evidence for chronic pain. They actually don't comment on exercise therapy or acupuncture, and I actually would advocate that these are things that you can use here. But still, you could be a good standing if you follow these recommendations. And then this is talks about our red flags and management of conditions that we're worried about other than nonspecific back pain. So again, I draw your attention to this AIM form as a reminder. Let's talk about medications a little bit more. And this is specifically on chronic low back pain, not the acute back pain. The reason is it probably doesn't matter. If they're going to get better, they're going to get better regardless of acute back pain. And so the question is, how do we manage the patient with chronic low back pain? Unfortunately, Tylenol does not seem to do very well when you actually look at it in the research. Although there is a low incidence of side effects as long as they're not heavy alcohol users. So it's certainly probably worth a try, but the evidence is not great for Tylenol. What about anticonvulsants such as Neurontin? And so Neurontin does have a role in patients with a failed back syndrome. Okay, and Topamax does seem to have a role too, but you have to balance these with the side effects. One of the roles that Neurontin may do is some of the sedation you can use to your benefit on there. What about antidepressants? There does not appear to be evidence for antidepressant use in low back pain patients without radicular symptoms. If they do have radicular symptoms, there may be a role for antidepressants. And Cymbalta did seem to help, and that is more of an SNRI as opposed to an SSRI. So Cymbalta does have a role. What about NSAIDs? Okay, so they seem to be helpful for patients without radicular symptoms, but those who had radicular symptoms, meaning some sort of nerve injury, they didn't seem to be helpful. That may be where you're going to use your Neurotins or your Topamax or your Cymbalta for the radicular symptoms. So NSAIDs don't seem to be helpful for patients who have radicular symptoms. And of course, there's all the adverse effects of NSAIDs. Botox is an option for patients with chronic back pain. And so that is an option to talk to your pain management providers for. Opioids have quite a bit of side effects with them, and there may be some short-term benefit from them, but I would encourage you to stay away from opioid use if possible. What about muscle relaxants on there? Really, their biggest effect is from their side effects from the sedation, and maybe they help sleep. Maybe there's some short-term effectiveness. However, there's quite a few side effects, and I don't advocate using muscle relaxants quite often. I do use lidoderm patches, and unfortunately the evidence is not great for those, although the side effect profile is really nil for that. So all the standard medications that people are using are the common medications, not great evidence for use in chronic low back pain. Can we prevent recurrences of low back pain? A recent study that was done and published in Spine had a 10-year follow-up, which is quite a bit, and they studied strengthening versus flexibility exercises with or without abdominal bracing, which we'll talk in a little bit, and what was their findings. And they found that frequent exercising and abdominal bracing seem effective for long-term prevention in recurrent low back pain, not flexibility, but it was frequent exercising. Can we prevent recurrences of low back pain? A recent study published in Spine had a 10-year follow-up of strengthening versus flexibility exercises with or without abdominal bracing. And we'll discuss what the abdominal bracing actually means. And what they found was frequent exercises with bracing did seem to be an effective long-term strategy for recurrent low back pain. But it was the exercise frequency that was the most important thing, and it was not the intensity or the type of exercise that was important. So the exercise frequency seemed to me the most important factor, and we discussed that earlier. In addition, abdominal bracing seemed to add to this exercise effect. And what is abdominal bracing? Well, essentially, if you just imagine you were preparing to take a blow to the stomach where you contracted these muscles, that was abdominal bracing. And so people did that frequently during the day. That seemed to be helpful, an additional effect to the strengthening and flexibility exercises that were recommended. And really, this is an isometric strengthening, so it was actually just another form of strengthening. So more credence to the concept that we talked before, that exercise frequency seemed to be the most important thing. So doing some sort of strengthening activity on a daily basis was the most important thing, and you were able to prevent recurrences of low back pain. These are the questions that we wanted to answer at the beginning of this presentation, and I think we've done that. The historic elements that seem to be most important are a history of malignancy, or a history of severe trauma, or a history that would make one think of an infection such as fever or previous instrumentation. Our physical exam consisted of testing the motor strength and the sensation and essentially the straight leg raise. We discussed those patients who needed imaging, and we also discussed the high frequency of asymptomatic findings on MRI and the need to correlate those with both the physical exam and what the patient's treatment goals are. We also discussed the management of the non-surgical patient and chronic pain patient, and those really rested on getting the patient moving and then initiating some sort of a strengthening regime on a regular basis. We talked about follow-up, and follow-up should be at essentially the 4 to 6 week window, and that will be where you find how your patient is improving and if they're doing their exercises. And probably most importantly is we did answer the question, is there a way to prevent recurrences? And the answer is yes, and that is some sort of regular daily strengthening regime coupled with isometric abdominal bracing. So the bottom line is there a serious systemic disease that could be causing your patient's symptoms? If the answer to that is no, then after your physical exam, is there a neurological compromise that requires surgical evaluation, either immediately or progressive when you do your 4 to 6 week follow-up? If the answers to those are all no, then you should initiate a strengthening program. This diagnostic algorithm that we put together at RX3 summarizes what we've just discussed in the following presentation. You'll do your brief history looking for any systemic processes. If those are positive findings, then you require detailed evaluation. Here you're looking for any red flags, such as any history of malignancy. Is there any bowel or bladder problems at all? Do they have any abnormal vital signs? If any of those are yes, that requires a detailed evaluation. Then you'll do your physical exam. Your physical exam includes gross inspection and then a test of your motor and sensory. Remembering we're looking for L4, L5, S1. L4 will be tested motor-wise by asking the patient to raise their foot. L5 will be tested by asking them to raise their great toe. And S1 will be tested by asking them to push down with their foot. And the sensation will be on the inside of the foot, on the top of the foot, and on the outside of the foot. And then the reflexes are only prevalent, are only there for L4, which is the patellar tendon, and for S1 at the Achilles tendon. If those are all normal, then you can feel comfortable recommending a rehabilitative program. We have provided a prescription pad which would allow you to check the box for the rehabilitative program that we've put together that can be found at the following URL, and that will take your patient to this screen, which they would click here, and this would walk them through a 3-phase rehab program that includes all the essential elements that we've talked about that have been validated by physical therapists, by orthopedic surgeons, and by sports medicine physicians, and you could feel comfortable recommending that program. In addition, we've built in some checks in the system that ensures that your patient is not harming themselves and that they're progressing in their rehabilitation. We've also put together this presentation, which you can find here, in addition to other resources. So we hope that you find this presentation on low back pain useful. We ask you to check out the resources we've put together here at the following URL, and we thank you for tuning in.